Hey everybody, this is Miss Shoemaker, and we're going to talk about family planning, infertility, and contraception. So, of course, if a couple decides they would like to get pregnant, it should be couple seeing any kind of counseling, of course, should be voluntary for both male and female. We don't want to drag the other, our significant other anywhere to, but it has to be voluntary, and the couple should be fully informed. So the first step to decide is whether they want to have children or not. And if they do want to have children, timing is everything. So, for example, throughout the years I've been teaching, I had quite a few students say, "Oh, after graduation, I would love to become pregnant." So, because we know nursing school is extremely stressful, and it might just not be a good time to try to have a child. So, there are may other be some life events that occur in a couple's life that they want to wait until till try after these events have occurred. Religious beliefs may play a factor. Some religions, of course, the couple should not be having intercourse before they're married, or their religion prefers natural family planning or something of that nature. The couple should be kind of checked out from head to toe. Do a rigorous physical exam for both men and women to make sure they're both healthy. What are they eating? So, for nutrition for a female, she should be taking at least 400 to 800 micrograms of folic acid at least 3 months before becoming pregnant. So if she knows she wants to get pregnant after nursing school and she graduates in May, well, maybe have her start, around February or so on that a prenatal vitamin. Um, Exercise, she should establish a regular exercise plan months before. And of course, anything she's doing prior to pregnancy, she can do as long as the baby and she is both healthy before pregnancy. And it'll be a wonderful idea to get totally immunized and ready to go when she has this baby. Because once she's pregnant, there are some vaccines she cannot get while she's pregnant. So for example, the rubella. She cannot get the MMR while she is pregnant, and she cannot get pregnant within 30 days of having this vaccine. So that's not the only vaccine that's like that, but it's a good idea to be immunized prior to getting pregnant. There'll be infertility lab workup for females and evaluation for males. And depending on what may be causing infertility problems, medication or surgical options will be discussed with the couple. They may discuss therapeutic insemination, IVF, donor egg, or something of that nature. But it's really up to the couple of what will they like to choose. Infertility occurs up to 10 to 15% of the reproductive age population. So if we all kind of sit back and think about it, I'm sure we all know someone, a female or a couple that has been affected with infertility. So factors that affect infertility for females may be ovulation disorders or PCOS, which is polycystic ovarian syndrome, any tubal or peritoneal factors like a tubal occlusion, any uterine factors, endometriosis, or history of uterine surgeries, vaginal cervical factors such as cervical surgeries. Anytime you have a surgery, it puts scar tissue there, which may inhibit fertility. So, scar tissue can sometimes be the main culprit. Now, factors associated with male infertility can be structural or hormonal disorder, undescended testes. Hypospadias is where the urethra is formed underneath the head of the penis, or maybe even on the shaft of the penis. A varicocele, which is a varicose vein in the scrotum. Low testosterone levels, which may lead to a low sperm count. Substance abuse could also affect the sperm's performance. So can be a lot of factors between the male and female. And once they kind of figure out what is causing it, then they could kind of hone in on that area and try to um, I can't say fix it, but work on it from there. So infertility is defined as the lack of conception despite unprotected sex for at least 12 months. Okay, um, and that primary for I should say infertility occurs in a couple who has never conceived. Okay. Secondary infertility occurs in a couple who has conceived at least once before, but has not conceived again during one or more years of unprotected intercourse. And I do know I have a friend who was just like this. She had her first baby after she got married, and then she tried for like 3 years to have her second child. And she was diagnosed with secondary infertility. And once they figured out the culprit, which was PCOS, polycystic ovarian syndrome, then once they kind of took control of that, then she was able to have another child. That's secondary infertility. Now you can imagine a couple who's really trying to have a baby and the profound emotional, psychological effect this may have on them. All they want to do is have a child, and everybody around them's having children, sometimes even unplanned, and it can cause a profound impact, on the individual and as well as a couple. Not even to mention the economic expense. Okay, so it can be incredibly heartbreaking and devastating for a couple. So elements essential for a normal fertility for a female. The female should have favorable cervical mucus, patent fallopian tube. So we don't want a fallopian tube with scar tissue. Ovaries that produce release normal ova with a regular cycle. Uh, Great endometrial lining, which is in a favorable state, which will allow implantation, and adequate reproductive hormones. Now, for the male partner, his testes must produce sperm, and those sperm need to be in normal quality, quantity, and motility. So they need to be able to. There needs to be a lot, and they need to be able to um, have great motility in order to reach that egg. The male genital tract must not also be obstructed, so we can't have scar tissue there either. And the male genital tract secretions need to be normal as well. So, like normal ejaculation, normal sperm count. So, when a person or a couple is having problems with fertility, there's a lot of guilt, isolation, anger, depression. They feel out of control, and there's a lot of grief. Okay, sometimes it's very hard for the couple as a whole. Um, for example, they may want to blame the other spouse. Well, it's your fault. Um, you had this surgery on, your uterus, or I don't know, and or it's his fault. So it can be very hard on a couple. So it's healthy to seek counseling and to identify coping strategies, help reduce the isolation, assess an available support system for the couple, and provide referrals and anticipatory guidance. Be a patient advocate, allow them to communicate, and just sometimes you just need to listen. Um, and treat the family in a holistic manner. It's not just the female, it's the couple. Okay, so but we need to treat the couple as a whole and not just one portion of that couple. Okay, so contraceptions. Some of the behavioral methods that are natural family planning, and fertility awareness methods such as coitus interruptus, which that's the fancy name for pulling out. You're stopping intercourse. Coitus interruptus. It sounds so fancy, but it's just pulling out. Lactational amenorrhea method, which I'm going to tell you firsthand, that does not work. That means breastfeeding. So, when a woman breastfeeds, if she breastfeeds full time, she may not get her menses, but she can still ovulate. And and they say even if you breastfeed full time, there's a chances, the chances are lower. But let me just tell you. Next time you see me in person, I'm going to introduce you to my two daughters who I was breastfeeding while my second one was conceived. And so that's a whole nother lecture on its own, but it doesn't work. And so just like our mamas taught us, abstinence is what works. Okay, abstinence, just like our mamas taught us. And then the barrier methods, such as the diaphragm, the cervical cap, and the condoms. And I will say the condom is the best one to help prevent STDs or STIs as well. Okay. We also have spermicides, which will be used with those barrier methods, the contraceptive sponge. And we also have some hormonal methods like the pill, oral contraceptives, low dose progesterone only contraceptive pills, transdermal patch, the contraceptive ring, and these are just a few. Clinical termination of pregnancy is ending pregnancy before a viable age. There's elective abortion, therapeutic abortion, surgical termination of pregnancy. There's complications, and one of the main complications would be bleeding and infection. Okay. Um, Vacuum aspiration is the most common method for a surgical abortion for pregnancies up to 12 weeks. Um, and then medical termination of pregnancy uses, of course, medication. And now we can this is these medications are over the counter now, and so but there can be a lot of complications involved. So before a woman would ever go seek surgical and or medication, she really needs to talk to her doctor, because there are risks involved in everything. Okay, so but other complications, maybe uterine, if it's a surgical, uterine perforation, cervical lacerations, hemorrhage, infection, and adverse affection reactions to any kind of anesthesia. Now, some of these natural family planning, we have the basal body temperature method. This is the first one we'll talk about. And this is a woman taking her temperature at the same exact time every morning upon awakening. Okay. So even before she sits up and leaves the bed to use the restroom, she sticks that thermometer in her mouth. Now, it has to be done at the same time every day. So let's say she wakes up for work Monday through Friday at 5 a.m. Well, she also has to do that Saturday and Sunday as well at 5 a.m. in order to be accurate. She takes her temperature and she plots it on a graph like you see on the slide here. Okay. Um, she does it before any kind of activity. And based on the fact that the temperature sometimes drops before ovulation and almost always rises afterwards, and remains elevated afterwards, that's where you can see where she ovulates. Okay, so it kind of drops, as you could see, her temperature drops before ovulation. And you could see it's only a few tenths. That's not even a whole number. Um, but it drops from her baseline right before ovulation. So depending whether or not she wants to have a child, then is whether or not she'll have intercourse at that time. The ovulation method, also the cervical mucus method, is an assessment of cervical mucus. So, with this method, the woman has to be comfortable with kind of inspecting her cervical mucus. So, it's assessment of her cervical mucus, and it changes with ovulation and becomes more clear and more stretchable, kind of like raw eggs. Okay, so she would actually put the cervical mucus in between her fingers and kind of stretch it. Okay. She wants to abstain from intercourse if she wants to not have a child right now. But of course, if she does want to have a child, she should have intercourse. But if she does not want to have a child right now, she should abstain until 4 days after the last wet mucus is noted. Okay. So let's look at this one. A 23-year-old Nola Paris client is visiting the clinic for a routine exam and tells the nurse that she desires to use the basal body temp method for family planning. The nurse should instruct the client to do which of the following: A, check the cervical mucus to see if it's thick and sparse. B, take her temperature at the same time every morning. D, document ovulation when the temperature decreases at least 1 degree Fahrenheit. Or D, avoid coitus, which is intercourse, for 10 days after a slight rise in temperature. And the answer is B as in boy. So right now, this question's asking about the basal body temperature. Okay. Um, A has to do with their cervical mucus method. And so B, we need to take it at the same time every morning. Okay. Um, document ovulation when the temperature decreases at 1 degree Fahrenheit, where if you remember the chart, it decreases and spikes up. Okay. And so, but it's asking for to instruct the client to do the following. So how to do the basal body temperature. And how we're going to do it is take the temperature at the same time every morning. All right, so situational contraceptives. We talked about abstinence, we talked about coitus interruptus, and your book also mentions douching after intercourse. Think about that. Do you think that would work? So when I was 15, my first job was in this little neighborhood grocery store. And I remember this man rushes in and he goes, do you have any condoms? And I'm like, I couldn't answer him fast enough because I didn't, if we did, I had no idea where they were. And he goes, what aisle are your douches in? And even 15-year-old Miss Shoemake put two and two together. I'm like, dude, that's not going to work because what is that going to do? It's actually going to push the sperm further up in the canal. So it's actually going to help those swimmers. So that's not working. Okay. Factors to consider when a method of contraception: safety, safety, safety. So if you didn't learn anything in nursing school, you need to just safety is always our priority. The effectiveness for the couple, convenience. Do they need a prescription? Do they have to see their doctor, or can they just want something over the counter? Availability, any side effects, expense, and education needed. So if you need to have a tutorial on it, maybe it's not the right method for them. Um, and preference, of course, for both men and women. Okay, it can't just be one-sided. Also, if the couple is not in a monogamous relationship, we need to protect from STIs as well. We also want to look at cultural and religious beliefs and personal beliefs. Um, Maybe a culturally sensitive topic for the couple, but it has to be addressed and acceptable of both partners, of course. Okay. So let's begin with spermicides. Spermicides, for example, the non-oxidil 9, we don't use it by itself. It's always used with something else. So it does not offer any protection, of course, against STIs. It does kill the sperm, but it's always used with something else. Like it can be used with the diaphragm, the cervical cap, the sponge, even the condom. It works best with the condom, but it works by physically blocking the passage of the sperm into the cervix and by releasing a spermicidal agent, which actually kills the sperm. So the spermicidal agent may cause a skin irritation and allergy. Barrier methods such as the male condom. This is probably the best method to prevent STIs and a pregnancy, but it's viable when used consistently. Of course, we need to teach our young men and women how to remove the condom, because if they don't remove it properly and this semen spills, then that's just for nothing. Okay, it should not be stored in a hot condition. So just think about this. Where do men store condoms? In their wallet. And where's their wallet? In their back pocket. And when they sit down, what gets all hot? Their back pocket. So their wallet and their back pocket is actually one of the worst places to store a condom. Okay, so if your significant other has a condom in his back pocket, tell you better replace that. But it does protect against STIs. It's quick, it's easy to use. Um, Yeah, it can be bought over the counter, but it comes in all kinds of colors. And even so, 'tis the season. I love pumpkin spice, and I had a student say, Miss Yumi, they even come in pumpkin spice. I'm like, well, that's one kind of pumpkin spice I'm not going to try, but um, but I was going to say let me know, but don't let me know. I don't want to know. But and there's also the female condom, not as popular, but works just as well. So it's a thin polyurethane sheath with a ring at each end. Of course, the closed ring, you could see where my cursor is over the cervix, and of course we have the open ring right here, which is outside of the vagina, of course, where the for the uh, penis to enter. Now, the diaphragm, this is used with spermicide jelly. It's inserted before intercourse and it covers the cervix. And this one has to be checked and fitted by a doctor. So if a woman gives birth or with each 10 to 15-pound weight gain or weight loss, it has to be refitted each and every time. Now, this has to be put in 2 hours before sexual intercourse. Now, for y'all listening, sometimes we just don't know we're going to have intercourse. So this kills the spontaneity. We may think like, okay, the kids are going to be home from school at 3. You have your lunch break at 12. I'm going to put my diaphragm in at 10 o'clock. So by the time you come, who does that? So that's really dedicated. That's a lot of dedication. And like I said, it does kill the spontaneity, but it must be kept in 6 hours after. Okay, because it has that spermicide kind of working on and killing the sperm, and it has acts as a blockade. So we want to kill all the sperm and stuff before we remove the diaphragm. Okay, so 2 hours before, 6 hours after. Now, after a person has intercourse, um, a lot of women forget that it's in. Even though it's supposed to be removed in 6 hours, they go on with their day. If it's at night, they go to sleep, or if it's during the day, they pick up with their day. They go back to work. They do their laundry. They start cooking dinner. I I don't know. There could be a million reasons, but it has. I have seen a lot of infections from leaving the diaphragm, the cervical cap, stuff like this in because a woman does forget. Okay. Um, but the female places the spermicide into the little dome of the diaphragm and around the rim, and that fits over the cervix, and it just stays there during intercourse. Okay, so here you can see the diaphragm again left in 2 hours before, 6 hours after. It is fitted by the healthcare provider after each pregnancy and after she gains or loses 10 to 15 pounds, and it needs to be washed well. And that is another reason I've seen a lot of infections in women because they just don't wash it well and they don't dry it well. Okay. And if there's any holes or tears, well, of course, that's not going to work at all. Okay. Now the cervical cap is very similar to the diaphragm. It's just smaller, just a little cup-shaped device filled with spermicide that fits on the cervix. Okay. And the vaginal sponge is a pillow-shaped, soft, absorbent synthetic sponge containing spermicides. And but the cervical cap is held in place by suction, and you can put the spermicide jelly around it and in the little, kind of in the middle there. And the vaginal sponge also has that, um, um, spermicide in it. Now you can see the vaginal sponge has a concave, like dimple that fits over the cervix. And we save the cervical cap. This vaginal sponge is discarded. The vaginal sponge is over the counter. Okay, so the vaginal sponge is not fitted um, by a doctor, but the cap and the diaphragm is. All right. So if you're a Seinfeld fan, or when you get a moment, this is just a little clip. It has nothing to do. You're not being tested on this. So, but I thought it was funny. Just a little comedic humor. I'm not going to play it right now. But you could play it. But if you ever watch Seinfeld, at one point the sponge was going off the market, and Elaine in Seinfeld bought all the vaginal sponges in Manhattan, and she saved them until she met a man and was wondering if he was sponge worthy. So it's kind of funny. There you go. All right. A 22-year-old Nola Gravid client tells the nurse that she and her husband have been considering using condoms for family planning. Which of the following instructions would the nurse include about the use of condoms as a method for family planning? A, using a spermicide with the condom offers added protection against pregnancy. B, natural skin condoms protect against STDs. C, the typical failure rate for couples using condom is about 25%. And D, condom users frequently report penile gland sensitivity. And the answer is A. Using spermicide with a condom offers that added protection against pregnancy. Now, the failure rate for a condom is approximately 12 to 14%. And again, we have to know the correct way to remove the condom. And again, if there's at least even a microscopic hole, then it won't work. That's while the failure rate increases. Because it might have a little tear or something to it. Natural skin condoms, such as lambskin, do not offer the same protection against sexually transmitted diseases or that are caused by viruses as latex. condoms do. Okay. Which of the following would the nurse include in the teaching for a 32-year-old female client requesting information about using a diaphragm for family planning? A. Douching with an acidic solution after intercourse is recommended. B. Diaphragms should not be used if the client develops acute cervicitis. C. The diaphragm should be washed in a weak solution of bleach and water. Or D. The diaphragm should be left in place 2 hours after intercourse. What do you think here? I didn't say it exactly this answer, but none of the other answers are correct. Okay, so the answer here is B as in boy. Diaphragm should not be used if the client develops acute cervicitis. So if where does the diaphragm go? Around the cervix. Okay, so the cervical cap kind of sits right on the cervix, but the diaphragm is a barrier method that is right by the cervix as well. It's just a little wider. And so if a patient already has an infection or inflammation of the cervix, do you want to put anything up there? No. D, the diaphragm should be left in place not 2 hours, but 6 hours. Okay. It could only be washed with mild soap and water. It doesn't have to use a bleach solution. And of course, we talked about douching, how that's simply not going to help. Now, the IUD is safe, effective, reversible contraception, but it's inserted by the PCP, and it can be left in place up to 5 to 10 years. It does have a high rate of effectiveness, but it's it's not 100%. I've had a patient one time who delivered her son with her IUD on his buttocks. So when the baby was born, the IUD was on the baby's buttocks. So it's not 100%. It does not protect against STDs. So this would be good for maybe a couple who's in a monogamous relationship or something like of that nature. Contains either copper or hormones and inserted into the female's uterus, and those prevent sperm from fertilizing the egg. Okay, it has this little string, whether it's copper or hormonal, and it should be checked. The string should be checked after each action of sexual intercourse or after each menstrual cycle. They just need to check the string is there. Okay. Now the pill is the oral or the combined oral contraceptive is about 99% effective if used properly. It can be considered safe, and I'm going to talk about this in a minute. It is highly effective if taken the proper way. And so the woman has to be taken the same time every day. If she forgets one, well, then it's not highly effective anymore. So the um, it a woman when I say it's safe, if the patient does not have a risk for thrombophlebitis, if she does not have a risk for high blood pressure, if she doesn't smoke, things like that. So she kind of has to be pretty darn healthy in order to be considered safe. So your book says it's safe, but I have seen a lot of women that do not use the pills because they have high blood pressures, high risk for strokes, clot formation, and they're heavy smokers. Okay. It does have to be taken every day at the same time. If she does miss one, well, she should use backup, even if she's on antibiotics. It can hurt the effectiveness of the pill, and she needs backup as well. Okay. Contraindications of the combined oral contraceptives, of course, a pregnancy. As soon as she finds out she's pregnant, she needs to stop the pill. If she has a history of thrombophlebitis, acute or chronic liver disease, estrogen-dependent carcinomas. This is some of the GYN cancers you learned in level 2. Undiagnosed uterine bleeding. So if she has bleeding and it's not her period, she should not be using anything hormonal. Nothing. If she's a heavy smoker, has gallbladder disease, diabetes, lipidemia, hyperlipidemia, this is a lot of reasons, which is a contraindication. So when the book says safe, you really have to take that with a grain of salt. All right. Some non-contraceptive benefits of the pill may be relief of uncomfortable menstrual syndrome. So if a woman or a young lady has like horrific menstrual cramps or PMS or something like that, they could use they could be placed on the pill to help relieve those menstrual syndromes. The progestin only pill, also called the mini pill, is safe for nursing mamas. And emergency contraception. So if there's contraception failure, the condom broke, or unprotected sex or rape or trauma or anything like that, there is emergency contraception out there. Other combined hormonal methods, we have the contraceptive skin patch, the vaginal contraceptive ring. Oh, I put patch here again. I'm so sorry. And the long-acting progestin contraceptives, such as the Nexplanon, which goes underneath the skin. It's like a little subdermal implant, and the IM Depo-Provera shot, and that's done every 3 months. Now, anytime a woman has a um, a birth control method that's hormonal, okay, it may not be the right fit for her. So let's say I've seen a lot of women get the IM Depo-Provera shot. Okay, some women bleed every blessed day on there, and some women don't bleed at all. So she may say, "Well, my friend doesn't bleed at all. Why is this? Why am I bleeding?" Well, it's just not the right method for her. So anytime there's a hormonal contraceptive, whether the pill, the implant, the patch, the ring, the injection, um, um, it may not work the same for everybody. So the woman does have to try to find the right fit for her as with her doctor. Okay. But how the hormones work, the hormonal contraceptives, is it thickens the cervical mucus and the endometrium to prevent sperm penetrating. Okay, and so that's how these hormonal contraceptives work. Of course, none of these protect against STDs or STIs. Okay. Before advising a 24-year-old client desiring oral contraceptives for family planning, the nurse would assess the client for signs and symptoms of which the following: A, anemia; B, hypertension; D, dysmenorrhea; or D, acne vulgaris. And the answer is that's right, hypertension. So the clients who do have hypertension, thrombophlebitis, um, a history of blood clots, even CVAs, are really poor candidates for oral contraceptives. Smokers, even now, they say women who are older than 40 um, or have pulmonary disease should also seek other methods. Okay. Operative sterilization. So tubal ligation, we have fallopian tubes that are clipped, ligated, banded, plugged, tied, burned, all the above, and that prevents the passage of the ova and the sperm. And then we have the e-shore, which is a little tiny stainless steel micro insert, which is placed into the fallopian tube. Now, the e-shore looks like if you break a tip off, if you're using your pencil and the pencil point breaks, it's kind of like the e-shore. It's like that's how tiny, or probably even tinier than that. It's a little stainless steel micro insert that's placed in the fallopian tubes and acts as a blockade. Okay. Um, with the e-shore, the woman needs to have an HSG every 3 months after to confirm there's blockage. Okay. Or HE 3 months after, I'm sorry, that it's placed. Now, of course, there's complications in both tubal ligation and the e-shore because it's surgery. Okay. So anytime a woman has surgery, of course, the risk for infection, anesthesia, all has to be discussed with that patient. Now, for a man, the vasectomy would be his permanent operative sterilization. It should be considered permanent, and it's where the vas deferens, which carries the sperm, are blocked, cut, tied, all the above. Another contraceptive must be utilized for 4 to 6 weeks. Okay. And so the book says there's a certain number of ejaculations to clear the tract of sperm. What's that certain number? It doesn't say because every single man is different. Okay, so he will have to get his sperm checked, counted in 6 months, and then again in 12 months, just to make sure everything has left the building. Okay, and here's just a picture of the bilateral tubal ligation, and of course the vasectomy. Now they are considered permanent. Are there reversal surgeries? There can be. And do they work? The rate is kind of low that they do work. And well, here I'm just going to tell you right now. Um, and it's out of pocket. Okay, so the disadvantages of sterilization methods for man or female, so does not provide against protection against STDs or STIs. It is surgery. So if a man or woman's not a candidate for surgery, this is probably not the best method for them. It should be considered permanent because reversal surgery is difficult, expensive, and the rate of success is kind of low. And reversals are not covered by insurance, so it is out of pocket. Okay. So infertility assessment. So questions for both genders. What's their history of sexual activity, the first intercourse, past number of partners, current and past, use of contraceptives, any kind of barriers to prevent STIs, or history of sexual trauma. So why do we have to know all this? Okay, well, just paints a more holistic picture of our patient. So look at the last bullet point. Does she have he or she have a history of sexual trauma? Um, if they have a history of sexual trauma, even though that may have been years and years ago, um, and they could have received all the counseling in the world, that every time that person has intercourse, that still may be on the back of their mind. Okay. Um, Barriers to prevent STDs. Do they ever have an STD before? Because as we know, some of these STDs can cause scar tissue. Okay, so did they use barriers to prevent STDs, or did they ever have one which causes scar tissue? Um, Use of contraceptives, again, what kind? And why do we know all about their sex life? Well, again, we want to look at, were they in any kind of risky relationships? Um, how many years they had been having intercourse, and what kind of protection did they use? We just want to get a better holistic picture. So when we talk about some therapeutic insemination, the therapeutic donor insemination, the TDI is artificial insemination. Therapeutic husband insemination is THI. And other unusual indications for THI may be oligospermia, which O looks like the number 0, which means little to none sperm. Athenospermia, which is low motility. Um, um, Teratospermia, which is abnormal morphology of the sperm. Any anatomical defects, ejaculatory dysfunction, or unexplained or female factor infertility. So there's some indications for THI. In vitro fertilization is selectively used with specific fertility factors. So a woman's eggs collected from ovaries and fertilized in a lab, and their embryos are placed in the uterus after normal development has begun. Egg retrieval is performed by a transvaginal approach to remove the eggs from the woman. And you gotta like this bullet point. Sperm is obtained using the natural method, which we all know what that is. Assessment. Again, we're going to look at the menstrual history of a woman, perform breast and genital exam. Why are we doing that? We just want to make sure all her reproductive, from head to toe, are healthy. Okay, that she doesn't have any cancers. Okay, because a lot of times, let's say, why are we looking at her breast? Well, breast cancers are sometimes closely tied to other gynecological cancers. Okay, so we just want to check out everything. Male will do a genital exam, ask about voiding, because if he has problems voiding, he may have trouble ejaculating. Okay, we're going to ask about his sexual functioning. We're going to ask ask the men to avoid saunas, hot tubs, because anything hot or that produces a high level of heat destroys those sperm. Menstrual disorders. We're going to assess a woman about her past menses. Amenorrhea is the absence of menses. Dysmenorrhea, anytime you see the prefix dys, dys, that means painful menses, painful uterine cramping. Or premenstrual symptoms is a range of symptoms associated with menstruation. It can become from just the hormonal levels rising and falling. It could be mood swings. It can actually be like muscle cramps and headaches and just a wide range of symptoms. Menorrhagia. Now, this is my favorite word, everybody. And of all the medical terminology you have learned within levels 1, 2, and 3, this is the best. So menorrhagia is uterine bleeding. That's not fancy. But if you put a little spin on it and say menorrhagia, darling, it just sounds so fancy. So picture like I'm sitting here with my pen. Picture like, those ladies in the old time movies with the long cigarettes or whatever those things were. Picture her going, let's talk about menorrhagia. And menorrhagia is excessive menstrual bleeding in duration or amount. Now, sounds kind of hot, doesn't it? But that's what menorrhagia is. Now, what causes menorrhagia are uterine lyomas, which is fibroids or myomas. They are the most common cause of menorrhagia. So a lyoma is a smooth muscle in a tumor of the smooth muscle of the uterus. Okay. Now, treatment of menorrhagia depends on the cause of the bleeding. It can be treated with some medication or surgical management. For example, if it is a lyoma or a fibroid, a surgical management to remove that lyoma or a fibroid. Okay. Dysmenorrhagia. Remember what I said about dys, that's painful. Okay, so primary dysmenorrhagia usually begins 1 to 3 years following a menarche, which is the beginning of a woman's period when she, young lady, and results from physiological causes, hormone imbalances, psychogenic factors, and increased prostaglandin secretion. Okay. Um, the pain usually begins at the onset of menstrual flow and can persist up to 48 hours. Now, secondary dysmenorrhagia is due to some other physical cause and is usually of later onset. Um, so, for example, women with secondary dysmenorrhagia also complain of painful uterine cramping with menstruation, have dyspareunia, which is painful intercourse, or non-menstrual pelvic pain. So they have pelvic pain when they're not even menstruating. The most common causes of secondary um, dysmenorrhagia may be pelvic adhesions, pelvic inflammatory disease, um, um, and just things like that. Okay, we see with secondary dysmenorrhagia, it's more common in women who are obese or smoke, and it's associated with early menarche, nulliparity, and even stress. So management of primary dysmenorrhea, be heating pads, hot baths, massaging the lower back, exercising. Exercising, that's probably the last thing you feel like doing, but it releases those endorphins. Medications may be like an NSAID, a non-steroidal anti-inflammatory to help with the discomfort and pain. Treatment for secondary may be removal of the underlying pathology and medications. For example, a D&C or even an endometrial biopsy to see what's causing this painful bleeding. Like I said, lyomas or fibroid tumors, they are the most common cause of what? Menorrhagia. And there are fibroids are the benign tumors in the smooth muscle of the uterus. Their signs and symptoms basically abnormal uterine bleeding and pelvic pressure. They're the main two symptoms. Okay. Sometimes a woman may have fibroids and don't even know them until they're discovered in like a pelvic exam or something like that. Okay. Treatment is usually removal of the fibroid or tumor, or maybe medication to shrink them, depending on how big they are and where they are, and also how many she has. So you can see here, this picture, we're looking at a few of them. I've had a patient one time, she was in her 80s and she looked like she was 9 months pregnant. That's how big her fibroid was. It was, of course, it's in the uterus, and as long as it was getting blood flow, it was growing. And it looked like she was 9 months pregnant. So she had, of course, to have surgery to remove that. Endometriosis is the presence and growth of endometrial tissue outside of the uterus. So these cells may be implanted on the ovaries, the vulva, the perineum, and the bladder. Patients complain of pelvic pain, dysmenorrhea, painful bleeding, and dyspareunia, painful intercourse. They may have chronic pelvic pain, pelvic heaviness, pain radiating to the thighs, diarrhea, constipation, everything in between. Okay, so treatment is usually laparoscopic surgery, or sometimes medication to, such as gonadotropin releasing hormones, but oftentimes I've seen surgery. Risk factors is early menarche before the age of 11, short menstrual cycles less than 27 days, heavy prolonged menstrual periods, and even infertility. Now, of course, this kind of double-edged sword, endometriosis also causes has a has its hand in infertility. Okay. There's also a strong familial component. First degree relatives, such as, mothers, grandmothers, have 7 to 10 times more likely to develop endometriosis. Okay. All right. Well, thank you for listening to me. And I want you to all use the term menorrhagia in a sentence today. And if you have any questions, please reach out to me. Thank you so much.